Migraine. Migraine represents a prevalent yet distinctive form of headache, characterized by recurrent episodes spanning several years. The typical migraine headache is pulsating and often accompanied by nausea and visual disturbances. Although severe, not all intense headaches are migraines, and some episodes may manifest mildly. Epidemiology: approximately 20% of individuals in the United States encounter migraine headaches at some juncture in their lives. A noteworthy proportion of these cases emerge during childhood or adolescence, particularly among females, suggesting a hormonal influence. Familial clustering is also observed, indicating a genetic predisposition. Key aspects of migraine epidemiology include: prevalence. Migraines are a widespread neurological condition, affecting approximately 20% of individuals in the United States at some point in their lives. The global prevalence is significant, making migraines a substantial public health concern. Onset and age distribution. Migraines can manifest at any age, but there are notable patterns in onset. Around half of migraine sufferers experience their first episode during childhood or adolescence, emphasizing the impact on the younger population. Gender disparity. There is a distinct gender disparity in migraine prevalence, with approximately 2/3 of migraine sufferers being women. Hormonal influences, particularly related to estrogen fluctuations, contribute to this gender discrepancy. Genetic predisposition. Familial clustering is a noteworthy aspect of migraine epidemiology, suggesting a genetic predisposition. Individuals with a family history of migraines are more likely to experience them, highlighting the influence of genetic factors. Hormonal influences. The prevalence of migraines is influenced by hormonal changes, particularly in women. Hormonal events such as menstruation, pregnancy, and menopause are associated with shifts in migraine patterns. Geographical and cultural variances. Migraine prevalence exhibits geographical and cultural variances. Certain populations or regions may experience higher or lower rates of migraines, potentially influenced by genetic, environmental, or lifestyle factors. Comorbidity with other conditions. Migraines often coexist with other medical conditions. Common comorbidities include depression, anxiety, and other pain disorders. Understanding these associations is crucial for comprehensive migraine management. Impact on quality of life. Migraines significantly impact the quality of life for individuals affected. The recurrent nature of migraines, coupled with their often debilitating symptoms, can lead to disruptions in daily activities, work, and social interactions. Chronic migraine. Some individuals experience chronic migraines, defined as migraines occurring on 15 or more days per month. Chronic migraines pose additional challenges in terms of management and impact on daily functioning. Healthcare utilization. Migraines contribute to substantial healthcare utilization, including visits to healthcare providers, emergency room visits, and the use of medications. The economic burden of migraines extends beyond direct medical costs to include indirect costs such as lost productivity. Pathophysiology. Migraine pain is linked to vascular swelling and nerve irritation surrounding the brain. However, the root cause of migraines is increasingly attributed to cortical spreading depression. Altered electrical waves gradually propagate across the brain, instigating a complex reaction involving the trigeminal nerve and adjacent tissues. Chemicals released during migraine attacks offer potential targets for therapeutic intervention, with serotonin, a neurotransmitter implicated in various conditions, playing a role. Key elements in the pathophysiological cascade include cortical spreading depression, CSD. A leading hypothesis suggests that migraines may be initiated by a phenomenon known as cortical spreading depression, CSD. This involves a wave of altered electrical activity that slowly spreads across the brain's cortex, triggering a cascade of events. Neurovascular involvement. The altered electrical waves associated with CSD are thought to stimulate the trigeminal nerve, a major cranial nerve. This stimulation leads to the release of vasoactive substances and neuropeptides, causing dilation of blood vessels and subsequent inflammation. Vascular swelling and nerve irritation. Migraine pain is linked to the swelling of blood vessels, vasodilation, and irritation of nerves surrounding the brain. While these features contribute to the pain perception, they do not fully explain the underlying cause. Chemical mediators. During a migraine attack, a release of various chemical mediators occurs. Substances such as serotonin, calcitonin gene-related peptide, CGRP, and nitric oxide are implicated. These chemicals play a role in modulating pain perception and the inflammatory response. Serotonin dysregulation. Serotonin, a neurotransmitter with various functions in the brain, has been implicated in migraine pathophysiology. Changes in serotonin levels are associated with alterations in blood vessel diameter and the transmission of pain signals. Trigeminal system activation. The trigeminal nerve system, responsible for sensation in the face and head, is activated during migraines. This activation contributes to the release of neuropeptides, leading to inflammation and sensitization of pain pathways. Genetic and hormonal influences. Genetic factors play a role in migraine susceptibility, as evidenced by familial clustering. Hormonal influences, particularly fluctuations in estrogen levels, contribute to the higher prevalence of migraines in women, especially during specific life stages such as puberty, menstruation, pregnancy, and menopause. Central sensitization. Chronic migraine sufferers may experience central sensitization, a phenomenon where the central nervous system becomes hyperresponsive to stimuli. This heightened sensitivity can lead to increased pain perception and the persistence of migraines. Symptoms. Migraines typically entail throbbing headaches on one or both sides of the head, accompanied by nausea, vomiting, or appetite loss. Light, noise, or activity exacerbate the pain, prompting individuals to seek a tranquil environment. Migraines last from 4 to 12 hours, sometimes longer, and are often heralded by prodromes, such as fatigue or nervousness. Auras, involving visual or sensory disturbances, may precede migraines, occasionally occurring without subsequent headaches. Rarely, migraines induce neurological symptoms like dizziness or numbness. Triggers. Migraines can be triggered by diverse factors, including specific activities, foods, odors, or emotions. Stress, whether as a causative or relieving factor, and hormonal fluctuations, especially around menstruation, are common triggers. Triggers. Specific foods. Certain foods can act as triggers, including aged cheeses, processed meats, foods containing MSG, monosodium glutamate, and artificial sweeteners. Keeping a food diary can help identify individual dietary triggers. Caffeine. Both excessive consumption and abrupt withdrawal of caffeine can trigger migraines. Maintaining a consistent and moderate intake is advisable. Stress. Stress is a common trigger for many individuals. Both acute stressors and the relief from stress, such as after exams or deadlines, can lead to migraines. Hormonal changes. Hormonal fluctuations, especially in women, can trigger migraines. Changes in estrogen levels during menstrual cycles, pregnancy, or the use of hormonal contraceptives may influence migraine patterns. Sleep disruptions. Irregular sleep patterns, inadequate sleep, or excessive sleep can be triggers. Establishing and maintaining a regular sleep schedule is crucial for migraine management. Environmental factors. Weather changes, bright lights, loud noises, and strong odors are environmental triggers. Managing exposure to these factors can help prevent migraines. Physical exertion. Intense physical activity or exertion, especially if sudden, can trigger migraines. Gradual and consistent exercise may be better tolerated. Dehydration. Inadequate fluid intake leading to dehydration is a known trigger. Hydration is essential in migraine prevention. Medication overuse. Overusing pain-relieving medications, whether prescription or over-the-counter, can lead to rebound headaches and exacerbate migraine frequency. Menstrual periods. Women may experience migraines linked to their menstrual cycles. This is known as menstrual migraines and may occur just before, during, or after menstruation. Travel and environmental changes. Travel-related factors, such as changes in time zones or exposure to different climates, can act as triggers. Individuals prone to migraines should manage these changes cautiously. Hormone-containing medications. Certain medications containing hormones, such as birth control pills, or hormone replacement therapy, may influence migraine patterns. Fasting or skipping meals. Going without meals for an extended period can trigger migraines. Maintaining regular and balanced meals is recommended. Alcohol. Certain types of alcohol, particularly red wine, beer, and spirits, can trigger migraines in some individuals. Monitoring alcohol intake may be beneficial. Diagnosis. Diagnosis hinges on clinical history and symptoms, as there are no specific diagnostic tests. Neurological and physical examinations typically yield normal results. Imaging studies like CT or MRI scans are often unremarkable. Consultation with a neurologist may be recommended for atypical cases or additional reassurance. Key elements in the diagnostic process include clinical history. A detailed account of the patient's headache history is essential. This includes the frequency, duration, and characteristics of headaches, as well as associated symptoms, such as nausea, vomiting, and sensitivity to light or sound. Symptom analysis. Analyzing specific symptoms, including the presence of auras, prodromes, and postdromes, helps differentiate migraines from other types of headaches. Not all migraines exhibit these features, but their presence can aid in diagnosis. Physical and neurological examination. A physical examination, including a neurological assessment, is typically performed. However, these examinations often yield normal results in individuals with migraines, reinforcing their reliance on clinical history for diagnosis. Imaging studies. In most cases, imaging studies such as computed tomography, CT, or magnetic resonance imaging, MRI, of the brain are not necessary for migraine diagnosis. These studies are usually normal in migraine sufferers. Specialized consultation. If there is uncertainty about the diagnosis or if the headaches have atypical features, a consultation with a neurologist, a specialist in nervous system disorders, may be recommended for further evaluation. Duration. Migraine durations vary from a few hours to several days. While some experience infrequent attacks, others contend with multiple episodes weekly. Identifying triggers can mitigate frequency and severity, although occasional migraines may persist despite efforts. Prevention. Recognizing triggers is pivotal for managing migraines. Common triggers encompass caffeine, certain foods, stress, hormonal fluctuations, sleep disruptions, and environmental changes. Despite avoidance efforts, occasional migraines may endure. Non-pharmacological interventions such as biofeedback, yoga, acupuncture, massage, and regular exercise may complement traditional approaches. Treatment modalities depend on attack frequency and severity. Non-prescription pain relievers suffice for sporadic headaches. However, disabling migraines necessitate more comprehensive strategies. Medications can be broadly categorized into abortive, taken during an attack, and preventive, taken regularly. Non-prescription pain relievers. For sporadic headaches, non-prescription pain relievers like aspirin, ibuprofen, or naproxen can be effective. Caution against excessive use, as it can lead to rebound headaches. Abortive medications. At onset of aura or headache, prompt use of abortive medications is recommended. Options include aspirin, acetaminophen, and caffeine combinations. Or prescription medications like triptans, sumatriptan, naratriptan, zolmitriptan, rizatriptan. CGRP antagonists, gepants. Newer oral options like ubrigepant and rimegepant, and the nasal spray zavegepant, work by blocking CGRP pain receptors. Preventive medications. Considered for frequent or severe migraines. Beta blockers, propranolol, nadolol, metoprolol, or atenolol. Calcium channel blockers, verapamil. Anticonvulsants, topiramate is often the initial choice. Antidepressants, venlafaxine, amitriptyline. CGRP antagonists, galcanezumab, erenumab, fremanezumab. Botox injections, considered for chronic migraine, more than 14 days per month. Nutritional guidance. Provide information on a migraine-friendly diet, avoiding trigger foods like aged cheeses, processed meats, and foods containing MSG. Encourage hydration and moderate caffeine intake to prevent dehydration-triggered headaches. Migraine-friendly diet. Offer information on a migraine-friendly diet that involves avoiding certain trigger foods. Common triggers include aged cheeses, processed meats, foods containing MSG, monosodium glutamate. Suggest maintaining a food diary to identify individual triggers and patterns. Hydration. Emphasize the importance of staying adequately hydrated to prevent dehydration-triggered headaches. Encourage individuals to monitor their water intake throughout the day and adjust based on factors such as activity level, climate, and individual needs. Caffeine monitoring. Advise individuals to be mindful of their caffeine intake, as both excessive consumption and sudden withdrawal can contribute to headaches. Recommend a consistent and moderate intake of caffeine, considering sources such as coffee, tea, and certain sodas. Alternative therapies. Mention alternative approaches such as acupuncture, biofeedback, and herbal supplements. However, stress the importance of consulting healthcare providers before incorporating these into the treatment plan. Psychological support. Recognize the psychological impact of chronic migraines and advocate for seeking support from mental health professionals if needed. Emphasize open communication with family, friends, and employers for understanding and support. Educational resources. Recommend reputable sources and patient support groups for additional information and community connection. Follow-up and emergency preparedness. Stress the importance of regular follow-up with healthcare providers to assess treatment effectiveness. Discuss emergency preparedness in case of severe migraine attacks, including when to seek medical attention. Abortive medications. Prompt use of abortive medications, such as aspirin, ibuprofen, or naproxen, is recommended at the onset of an aura or headache. Drug combinations, like aspirin, acetaminophen, and caffeine, may enhance efficacy. Prescription options include isometheptine, triptans, sumatriptan, naratriptan, zolmitriptan, rizatriptan, ergotamines, and anti-nausea agents. CGRP antagonists, like ubrigepant and rimegepant, represent newer oral options, with the nasal spray zavegepant available for pain relief. Preventive medications. Daily preventive medications are considered for frequent or severe migraines. Beta blockers, propranolol, nadolol, calcium channel blockers, verapamil, anticonvulsants, topiramate, and antidepressants, venlafaxine, amitriptyline, are commonly prescribed. Chronic migraine, occurring more than 14 days per month, may warrant Botox injections or newer CGRP antagonists like galcanezumab, erenumab, and fremanezumab. Lifestyle modifications. Prioritize regular sleep. Stress the significance of maintaining a consistent sleep schedule by going to bed and waking up at the same time each day. Discourage irregular sleep patterns, as inadequate or excessive sleep can be a trigger for migraines. Stress management techniques. Encourage the adoption of mindfulness practices to help individuals stay present and manage stress effectively. Suggest meditation as a valuable tool for calming the mind, reducing tension, and potentially preventing migraine episodes. Advocate for the practice of deep breathing exercises, such as diaphragmatic breathing, to promote relaxation and alleviate stress. Regular exercise. Highlight the positive impact of regular physical activity on overall well-being. Recommend incorporating aerobic exercises, such as brisk walking, swimming, or cycling, into the routine, as they have been associated with a potential reduction in the frequency of migraines. Encourage individuals to choose activities they enjoy to enhance adherence to a consistent exercise routine. Your health matters. Quali.health